Hi, and welcome to the Anti-Waffle podcast of Em and Pixie.
Hello!
And together we'll try to talk about research about any gobbledygook. Each episode we'll be talking to a researcher who will discuss the work they're doing, looking at why this research is important and asking how do they get into this field. We hope that it will be informative and interesting and bring a bit of the academic world into the real world. Today we have Dr. Lisa Gould, who's a research fellow at the Institute of Global Health Innovation at Imperial College London. Hi Lisa, thanks for being here today. It's lovely to talk to you. So do you want to start by telling us about your research?
Yes, so I'm a psychologist by background and I did a PhD in clinical neuroscience. And what I do for Imperial at the moment is I work for their patient safety translational research centre, which just basically means we look at making patients safe while they're receiving healthcare. And essentially making them better from participating in our services and not worse. So one of my areas of interest is looking into how we look after people who have who are living with dementia in hospitals. Because what happens very often is people who are living with dementia go into hospital, not for their dementia, but for other comorbid conditions. So, for example, they might have had a fall or something like that, and they go to receive treatment for that. And then when they're in hospital, they do experience quite poor care outcomes. And it's a really, really big problem. We have sometimes up to 1/3 of all of our hospital beds occupied by people with dementia. So we have a huge amount of people coming into hospital who have dementia, and we aren't terribly well equipped to look after them. So what's happening to these people is they're coming into the hospital, they are more likely to have longer stays, they're more likely to have a clinical incident during their stay, they're more likely to lose their ability to do the things that they could do before. So things like getting up out of bed, going to the loo, brushing their hair, brushing their teeth, all those kind of things, what we call their functional decline. And that happens quite prevalently with people with dementia. And they're also more likely to die from a hospital admission than people who are the same age as them, with the same condition, but without the dementia. So it's a really tough one, and it does make their stay extremely difficult. On the other hand, it's also very challenging for staff to know how to care for people with dementia, because although the NHS strongly supports person-centred care for people with dementia, which is a way of looking after them that kind of supports their personhood. So it tries to move away from hospital being quite an institutionalized place, where you have your breakfast at 9 o'clock and you have two choices, and then you have your shower, and then you're allowed to sit in your chair for half an hour for your lunch, and then someone gives you a packet of sandwiches. And this whole routine, it doesn't work for many people anyway. But if you have something like dementia, it really doesn't work for you. And even, so one of part of my job was to sit in a hospital and watch older people receiving care. So I spent many hours sat in the corner watching kind of care that people receive. And you see these sandwiches being delivered and put on people's tables, and they're not opened, and the patient can't open the sandwich. And then half an hour later, someone else comes along, takes the sandwich away and says, "Oh, you didn't want your lunch then." So they haven't eaten. They don't have the right cups, so they can't drink. Katie Featherstone and Andy Northcott did a wonderful hospital ethnography around people, continence care for older people, and it's just been in the BBC News actually. And they showed some of the difficulties for older people and people with dementia in hospitals. And one of the things that they talked about, which I thought was fantastic, was soup. So why do they serve people soup in hospital? Because they can't. It's a difficult thing to eat when you're sitting in a bed anyway. So these poor people with, who are living with frailty or who have, a little bit more of a reduced mobility, I just can't get the food in their mouths. And we don't have people to spare to feed people and to sit and to do assisted lunchtime, assisted meal times. So there are some very, very simple care things that aren't occurring in hospital because we don't know or we don't have any training that is both person-centered care training and person-centered care for people with dementia. So that is quite a specific combination. So that's part of one of my research streams, is to try and get an intervention developed and rolled out in hospitals that will enable staff to do this.
Absolutely essential work. So one of the things you were saying at the beginning, you were saying that that they come out of hospital and lose some of their mobility. Is that why? Yeah, why is it? Is it because they would anyway if they were at home because of the dementia, or is it because they've been in hospital so long that they've sort of like become dependent on, or just used to just sitting in bed all day?
Yeah, so with older people, in much the same way as it is with the younger population, but even more so, they have this use it or lose it capacity. And once they have lost the ability to do something, it is much, much harder to maintain it. But also the tendency when you're caring for an older person is to put them in a bed and expect them to stay in that bed. And to so one of the things that Katie Featherstone was discussing in the BBC was continence, and what they did. What happens is an older person goes into hospital, and they're immediately put on a pad. So what they call pad culture, and that older person may be perfectly capable of taking themselves to the toilet at home, but they've said, well, you're not well, and you're in hospital now, and we're putting you in a pad. And partly that is because they are concerned about risk, about falls. And, an older person who has delirium, may be safer in bed with continence care. The other part is also it takes more staff and more time to take people to the toilet all the time. And you can do that and you can do it safely, but it does take time. And it does take correct staffing numbers, which we know is a massive issue in the NHS at the moment. So these people are going into the hospital perfectly able to go to the toilet. They spend a week in bed on a continence pad, and that use it or lose it principle goes. And then they go home and they're on a pad.
I was speaking with, I was listening to Catherine Ryan being interviewed, the comedian, and she was saying that with her babies, what she has done is that she doesn't put them in, she put them in nappies like for the first few weeks, but starts the process of nappy training and getting them onto or toilet training, potty training, almost straight away. So she'll start putting them on the potty and reading to them so that they understand that, oh, this is where you go toilet. So and it does make sense. She was saying that we train the babies to go toilet in the nappy by putting them in a nappy, and it's the same thing, isn't it, with the incontinence pads?
Yeah, I mean, also like there's a massive dignity issue attached to this as well.
Yeah.
So we say to this older person who up until the point of hospital admission has been using the toilet, just go in your bed. And there are mixed sex wards. It's not a private space, and they're expected to just go to the toilet and just soil themselves in their bed. That is not what they would do at home, even if they bring in a commode. Sometimes, and that, I mean, in hospital, I think it's slightly better. I know in care homes, it can be done quite poorly as well. Is that the commode is wheeled into the curtain space, and then they're expected to go to the toilet, in one small blue curtains width away from the person in the bed next door. And yeah, so preserving personhood and preserving their choices is really important. And there are also different things. So like they're expected to go to bed. So one of the papers that we had out recently was written, first author was my colleague Jo Hope, who wrote about Goffman and the total institution, and sort of wove into this paper around how institutionalized hospitals are and how there is that expectation that will go along with this. And so some of the patients, the people who come in, particularly those who are living with dementia, will get up in the night. And that is quite habitual, and it's quite a normal part of that condition. There is a lot of circadian rhythm disturbance. There's a lot of sleep time wandering. And it is just inherently by having that condition, they will find it difficult to sleep at night. But the expectation on the ward is the lights go out and everybody goes to bed. Mm-hmm. So their capacity to deal with nighttime wandering is very limited. And of course, it disturbs other patients as well. And you wouldn't necessarily want to put a person living with dementia in a single room, because often you put them closer to the desk so that you can see them, and that you want to have a good level of visibility with those patients. So it just doesn't work terribly well, and it's not an easy thing to work out exactly how we should be caring for people with dementia and what the best thing to do is. So I was very, very lucky to win a Worldwide Universities Network funding to travel to Australia to spend a couple of weeks with a professor over there called Professor Lynn Chenoweth from the University of New South Wales, who is, I think, one of the nicest women I have ever met in my life. She was absolutely wonderful, and you could really, really see why she did the job she did. I mean, she was an absolute exemplar of compassionate, caring behaviour. So that was lovely. So I travelled over to Sydney, and I met with her, and she had developed one of the world's only empirically validated training programs for using person-centered care to improve agitation in people living with dementia who were in care homes. Yeah. So together we've adapted that training program for use in hospitals, and we're now wanting to roll it out in the UK, or get some funding to roll it out in the UK. I'm holding focus groups at the moment with people living with dementia and their family and carers, to try to work out what the priority setting exercises need to be over here, and how we can also potentially use digital technology to help us, particularly with the communication that needs to happen between carers, family members, and clinical teams in the hospital. So that's my goal at the moment.
Wow.
If you can empower people, it's part of their welfare, isn't it? And they're making them feel better if they can be treated for their own individual needs as well as what they're in there for.
No, and I was just saying, yeah, absolutely. And I think the consequences of not doing it, for somebody who doesn't have a cognitive impairment, it is, that it's not great, and we don't feel that we're being given a lot of options and stuff. But the consequences for not doing it with somebody who has dementia is that you get non-compliance, and you get a much higher incidence of agitative behaviours, which sometimes we call challenging behaviours. And the onus of this is then put on the person. They're a difficult patient, but actually things like getting medication into people, carers and family members may have an excellent solution for how you get this person to take their medication. But you don't know that. So you're just saying, well, take your pill, and they're not taking their pills. And then you get into this situation where everybody's extremely unhappy, and it's taking a lot of nursing time. And it's also taking a lot from the patient and their family as well. So it's so important, person-centered care for these population. And they are also one of the least likely populations to receive it.
So with this research, are you working with particular hospitals at the moment?
Yeah, so at the moment I work for St Mary's Hospital at Imperial College London. So that's the hospital that I would be attached to, and I work with Mary Wells, who is the Director of Nursing Research, and we're hoping to engage some staff in the development of the intervention. It's a complicated intervention. I mean, like everything else, this is not a standalone training section. There's something that has to be delivered, recognizing that we're working in a very overburdened system, but looking at it at a systems level too. So involving different management hierarchies, involving ward culture and clinical teams, rather than just saying, okay, hey, you guys, you need to care for these people better. This is how we think you should do it, from our ivory tower in the university, where we're looking down at all your work and how exhausted and burned out and everything like that you are. So it's co-design is going to be really important, and including the staff, and particularly nursing teams. So I've worked on a compassionate care study and a person-centred care study, which were cluster randomised. So they're aimed at training an entire ward, and doing that whilst recognising that this is, one cog in a big machine. And we have to understand the pressures that the people we're working with are under as well. And we need to work with them to develop a programme that is going to suit them and suit their ward and suit their hospital.
Right, because it is what's coming to my mind as you're talking about it. I mean, it's as I say, I think it's fantastic. But one of the challenges that I see that's coming in is that, especially like you were saying about the soup. So it's because it affects every area, whether it's the food or the care in the hospital, or or toileting, or whatever it is. Every aspect of the patient's journey is affected, and every person will be needing this training. So where are you starting? So I know, like, you're at Queen Mary's Hospital, but are you going to start with the nurses? Do you start with the catering? Do you start with the doctors? How do you start? What's the plan?
Yeah, you're right. It is a huge thing, and it would be wonderful to have every member of staff involved in the training. Where I would want to start is I would start at a ward level training program for the nursing teams, and that includes healthcare assistants, so an agency staff, should they want to participate. So you deliver the program to them, and then what you'd also do is you would get the hospital to nominate some, or to enable people to self-nominate themselves to be champions of this program. And you've got to get buy-in, right? So you can also get your training program validated so that it contributes towards the nurses' ongoing education, so they get points for it, for their revalidation. So that helps them too. So you have the ward that you train. People who become interested in it can become champions, and the idea is that it's called contamination. So once you've trained your one ward, other wards may then go, oh, actually, this looks quite good. We're quite interested in this. And you can have a sort of, I mean, they wouldn't be able to do it with us, but what you can do is we trained the person who delivered our training in one of my previous studies was attached to the educational department of the hospital. So you also leave them the resource, you leave them the trainer, you leave them the training pack. So once you've done your one ward, the idea is that the trainer, if the hospital so desires, could also go and train other members of staff. Initially, you'd want to do it as an RCT. So straight away, you'd actually want to have your ward. You wouldn't want contamination, and you want to compare it to a normal ward. And then if that is successful, then you can scale up by doing things like this. But I did some work in Portsmouth Hospital, and we used that model, and we did our RCT, and then we left and continued to support them through their education department, and they actually went on to train another 2 or 3 wards by the hospital adopting and owning it and saying, actually this is really helpful to us, so we're going to use it. So, it's a big problem. I mean, if it worked, if we did an RCT and we found significance, so one of the things I'm looking at agitative behaviour and inappropriate prescribing. So prescribing of psychotropic drugs, particularly antipsychotics, is particularly expensive, difficult, and it's very suboptimal for the patients as well. So if you can show a significant reduction in those kind of things, then obviously you can look to get some money to upscale it and roll it out.
Wow. No,
That's
brilliant work. A mammoth task.
Yeah. I mean, there are a lot of other people working in this area who recognise that we do need care improvements for people living with dementia who go into hospital. And I think it's very similar. So we also have people with learning disabilities who go into hospital, receive quite inequitable care, and often come out, worse than they went in. So there are a sort of vulnerability in any person who has a cognitive impairment when they go into hospital, particularly those who lack advocates. And I think there is a big movement towards trying to address that. There's also some barriers that we come up against in academia, in our sort of clinical structure, to get these kind of studies off the ground. So one of the problems I have found is with the ethics boards. So they're still, despite a lot of research coming through from Alzheimer's Society and Dementia Voices and things like that, that say that members of the public who have dementia or who care for somebody with dementia want them to be involved in this kind of research, ethics committees are still very reticent to give permission for you to involve somebody who has fluctuating capacity. And it's a difficult task. You have to be very well informed, and you have to make sure that you are capturing consent, but with the understanding that actually you can change your consent models to make this research participation more accessible for people who have dementia. You don't just need to say, oh, no, you've got dementia, you can't make any decisions for yourself, and we're not going to allow you to be part of this research. And I think they are stepping away from that, but they're stepping very cautiously away from that. So I was given
understandable, but I see it both sides. So it's like, because how will you know whether they've genuinely change their minds, or if it's genuinely the symptoms of their disease that is causing them to say, no, I don't want to do this today, but or I don't know what's going on because of the dementia, they don't know what's going on. So yes, no, it's very, very difficult, but well done for taking on the challenge.
It is a challenge. I did get, there was one board who gave me permission to include people with dementia who had what we call a personal consultee. So if a member of a family or friend was able to give consent for them, acting, considering how the person with dementia would feel about the research and what they think their views would be, and offer that, and we could accept that as consent, or and so they could be saying yes or no in that capacity. But they told me I wasn't able to include people with dementia who didn't have a personal consultee. But what that actually meant was that, so in that instance, I would have asked their GP or somebody with a professional capacity with a care responsibility for them. And what that meant was that people who didn't have relatives or friends looking after them or out for them or advocating for them could not be included in the study. And that subgroup is extremely vulnerable to poor care. and poor care outcomes. So actually, by having that process in place, we had to systematically exclude the most vulnerable group of people from our research, and also the people who would more directly benefit from care changes. So there are a few barriers to getting this kind of work off the ground.
There are, every side. Wow.
Incredible work, though. That's just
it's well, I love doing it, and it's brilliant stuff. And I have to say, so what inspired me to get into this area was I worked for Southampton University in a compassionate care study, and part of my role there was to do this this kind of ethnography work, sitting in the hospitals, watching and sitting on my hands with my mouth closed and that was hard, and just seeing the care failings. It was very, very powerful, and you do come away thinking we absolutely can fix this. It doesn't have to be like this. It's not a difficult. I mean, operationally it is, but conceptually, if we can just get this across, then I think it will make a massive difference. And when you talk to patients, and when they do systematic reviews of older people's care and older people's experiences of care in hospital, like my old boss, Professor Jackie Bridges, did many of these, what older people say is the thing that really sticks with them about their hospital experience is the care that they receive, the communication and the relationships that they have with hospital professionals, rather than, did they fix me or did they make me better? It's the quality of the care that is very, very important to an older person going into hospital. So we know. And also, when it comes to complaints and things like that, the majority of complaints are not around the physical care. It's around a relational aspect of the care. So I think there was a study that showed GPs that touched their patients, put their hand on their patient's hand, received a massive decrease in levels of complaints.
Right.
Because they were sort of encouraged to create a personal relationship and show compassion, and that therefore meant that when there was an issue, it wasn't put into a complaint and filed.
Right. No, that makes sense. Well, I always say that with customer service and any company, it's like I don't expect that things are never going to go wrong. What I'm looking for is how you deal with it when it does go wrong, and how you make it better or make me feel about it. Because sometimes there are some things you can't fix. Or you cut off the wrong leg, you can't fix that. But how you speak to me about it and how you make me feel like that it wasn't my fault, so it's that's it's extreme example, but it's true, and it's very true.
Could you tell us, how did you get into this area of research? Where did you start from?
So I starting from was my degree, which I did in psychology, and I really enjoyed that, and then I came out of it and thought, God, I'm so sick of exams. I really don't want to do any more exams. I'm done with it. I've had my fill of education. Then I looked for a job, and I realised that the kind of jobs they were offering me, even though I had this first class psychology degree and thought, yes, that's it, I've made it, and I'm going to get a great job. And the kind of jobs I was being offered were quite poor, and even like care assistant posts and things. And then they which I'd hoped I'd been doing as I went along. So I was already doing that position, and they were offering me the thing that I'd been doing for the last 3 years, getting the qualification that I was hoping was going to take me up higher than that. So I was hoping to move up. But that didn't happen. And then my dissertation supervisor sent me an email saying, I think you should consider applying for this PhD funding that I have. And I realised the funding was actually kind of similar to what I'd get paid. So I thought, oh, maybe I will have a look at staying in academia and doing a PhD. And I actually found a different PhD that I liked, that sounded a bit more. So the PhD I was doing was within. I was offered was in psychology, but the one that I actually went for was in clinical neuroscience, because I thought that sounded a bit cool and I like the topic area. And my boss was a brain surgeon, and I had two bosses, one brain surgeon and one behavioural psychologist, who were like, yeah, brilliant, Liam Gray and Ed Redhead, and that was a fantastic experience, massive learning curve, because I went from being a psychology student to then 3 months later having said, that's it, I'm done with education, sitting in a lab, cutting up rat brains. And there was a point, particularly sort of midway into my degree, when I actually, I was standing in Boulderwood campus in scrubs with brain in my hair, just thinking, Christ, how did I get here? Yeah, so it was a big difference, and I actually realized from doing that I found the lab work quite repetitive, and I wasn't great at it. I remember my boss saying to me when I first started, lab work is like cooking, and you're good at cooking, and I was like, well, I'm all right at cooking. So we cook totally differently. I cook by throwing a bit in here and a bit in there and stirring it and tasting it and shoving it back in the oven for a few minutes. He means like proper cooking, where you weigh your ingredients and you make sure that everything is exactly perfect. And
not beans on toast cooking. No,
that's not my cooking. So I ended up.
I hope you weren't tempted to taste the rat brains or anything.
No. One Christmas they went mouldy because the fridge broke down, and I literally spent the entirety of Christmas Eve washing out my mouldy brains. And again, that was another moment I was like, "What the heck?"
That's so gross.
Yeah, it was. And I don't think I finished until like 3:00 Christmas Eve night, and I had to get them done. So it was interesting. But yeah, so I did realise from that I wasn't really going to pursue a career in the lab work, and I'm sure the lab are no worse off for that. I did manage to come through my PhD. I loved working with the humans, as I would refer to them at the time, and working with people who had suffered memory loss and had brain surgery to treat temporal lobe epilepsy, and I would work with them on how they were managing their spatial navigation. And yeah, so I really enjoyed that part of it, and that's the part that I have kind of taken with me throughout my career, is that working with people with cognitive impairments, neurodegenerative diseases. I had a couple of postdocs after that, but my best one was the one that I started in health sciences in Southampton University in the compassionate care research, and that was good for many reasons. One, because I loved the subject area. I loved the fact that we were in a hospital making real difference to patients' care, and the second part was my boss, who was a really, really, really good boss. And I think in academia you can get in these situations where you're sort of brought in to do the job and then thank you very much, goodbye, especially at postdoc level. And she was totally not like that at all. And I guess heading a compassionate care program, she's probably not likely to be, but she was very, very nurturing and very, tried to sort of bring us up and develop us along with the project. And so I stayed there for quite a long time, and I really enjoyed that post. And then from there, I sort of ended up sitting in the hospital watching care delivery, and that's what got me interested in the project that I then developed myself.
Brilliant. That's quite a journey.
We went from rat brains to hospital beds.
Oh, brilliant. That's good. It's always nice to hear how people make where the choices take you. Can you sum up why your research is so important?
So I mean, I think that the research is incredibly important. I think it's important because we have an aging population. We have a huge amount of people who are now being diagnosed with dementia. We still have no cure. And we have an awful lot of people in hospital who have dementia, and economically, that costs an absolute fortune. I mean, if 1/3 of the hospital beds are occupied by somebody with dementia, and the way that we care for them is increasing clinical incidences, length of stay, and mortality, we're causing ourselves a phenomenal outlay in this. And whilst it is wonderful and we have fantastic efforts going to develop the treatments, all we need to do is to care for them properly, and we can help them right now. Not in 2 years' time when we get this drug, or 5 years' time when we get this job. We can increase their lifespan, their quality of life, and their functional, their abilities to do their everyday tasks today, right now, with the right kind of care that's being delivered in hospitals. And that's an opportunity we are missing day in, day out to improve care with a resource we already possess. Right. So I think that's really, really important.
Oh, thank you so much, Lisa. That's really great. Thank you to everybody for listening. We'll put up links on our Twitter account, which is @Anti-Waffle Pod, and please do get in touch, as we'd love to hear from you. Bye.
Bye.